So hi, everyone. Welcome to Faves number 15. So I'm Jessica from Phage Directory, and we're here today. This is a little bit of a different setup as from our usual. Usually we have seminars, but we're doing an interview, and sometimes we do these. So I've got Dr. Randy, here with me today. And Randy is a podiatrist, and he has used phages to treat diabetic foot infections. And so he's kindly offered to be the first in a new series that we're doing, kind of a sub-series within our usual faves, where we're looking more at the clinical use of phages. And so we're getting a lot of questions from clinicians who want to use phage for their patients. And we're hearing that they don't have a lot of places to hear from people who are actually trying this. Occasionally, there's a phage conference, but we need kind of more informal times to talk and to just hash out the details. So I'm glad you're all here and excited for this new sub-series, and we'll see where it goes, but we're gonna play around with format and keep it pretty casual, but just kind of hanging out so we can all, and meet a few new faces in the field so you can have people to go ask your questions to. Maybe you're thinking about using phages in the clinic, maybe you want to be part of a study, or you're, whatever missing puzzle piece that you need. Maybe you can find it here. And then at the end of the interview, so I'm going to do kind of an interview with Randy, and then please ask your questions in the chat as we go. Then I'll open it up to those questions, and then we're going to do a breakout room after, like we usually do, so you can kind of meet, you can turn on your video and unmute and meet a couple other people for a few minutes, but that's of course optional, and that part will not be recorded. So with that, welcome, Randy. Nice to have you here. And so why don't we talk first about, your background. Where are you in the world and what do you do in a given day?
Well, I'm right now in lovely downtown Tacoma, Washington. I'm a podiatrist. I graduated before there was dirt, and it was a long time ago. But I was in school in Philadelphia, and during my third year, these interesting people would come in off of the street. We call them the Race Street Irregulars, as an homage to Arthur Conan Doyle. And they had ulcers, and how do you treat those? And there's really nothing written. And so I took an interest, and I kind of kept going. So it's been over 40 years now.
Awesome.
So.
And I'm kind of really curious if you can kind of paint a picture of, what is an ulcer in the diabetes context, diabetic foot ulcer? What does that, what causes it? What's it like for you when you go to treat that?
Well, ulcers are obviously just openings in the skin. The problem is how they get there, because generally there's a reason. Most of the time there's some sort of a pressure point, especially podiatrically. There's always pressure ulcers, and I suppose a lot of these are pressure ulcers, but the insurances like the word diabetes first, so we're going to call them diabetic ulcers. And the problem with them is that there's a pressure point, there is very poor circulation. A lot of times, in fact, the majority of the times, their diabetes is not in control. And it's not been in control for a long time. So basically, the tissue I'm working with is very poor quality. So it just takes a long time. And then it's compounded by the patients themselves. A lot of them have dementia. A lot of them have, they have to work. They can't get pressure off of their foot, for example. So it's a kind of a constant fight to get a handle and get on top of that skin opening, wherever it is. Obviously, it's on the foot somewhere, but sometimes they're just in fact, so we can't actually cure all of them. And then you get one that's infected, and now you could have a very big problem, because they can get very sick very quickly. So if somebody comes in with an ulcer that is infected, we have to get on that right away. And that's where the phage came in.
Right. So perfect lead in. So how did you figure out that phage is even an option? I imagine that's not a standard part of your dietary training.
No, I think there was a paragraph in a book about phage, but luckily, um, when I went to college, I was a student of Elizabeth Cutter, Betty Cutter, at Evergreen State College, and she was working with phage. This is in the mid '70s, a long time ago, and so that's how it was introduced to me. And so many years went by. And I was at a conference one time, and somebody asked about using phage to the speaker. I was sitting in the back, being very quiet, and so I had to go up and talk to him later. Where did he hear about that? And he says, "Well, Elizabeth Cutter is my neighbor." Well, so we got together again. She said, "I need some diabetic feet." And I said, I know where to get some diabetic feet. What do you want to do?" And so we started from there. And so that's how I got back into phage.
Got it. Wow. Yeah. Because I know that diabetic foot ulcer is thrown around, at least when I was a grad student, even, and it was thrown around in the phage world as kind of like the low hanging fruit. Like, this is the place. Maybe I was just heavily influenced by Betty going to Evergreen. But I remember hearing that all the time. Like, people saw that as a really good place to try phages. So yeah, you've clearly gone that direction. So maybe we could talk about when you did actually use phages on patients. You published a case series in 2016. So what was that? What was that like to, and what did you see? Like, did that surprise you? How did it go? Let's talk about that.
We had published in 16, but I actually started using phage probably around 2012 or 2013. I had a patient with a staph infection, diabetic. Literally, when he came in with it, it occurred over the weekend. He had a hole in a toe, but he also had loose bone. You could reach in and flip a piece of bone around. So when I took that bone out, I flushed it out and I filled this little pocket with phage. And he came back in a week later and looked 100% better. And he said it got better. He could tell after 24 hours. And so we went 2 or 3 weeks and injected phage, and he just kept getting better, healed right up. And I said, "Okay, wait a minute, we got to look at this." So every patient that I use staph only, and the ulcers are polymicrobial. We've looked at that. However, they're not all pathogens. What's the biggest pathogen in foot ulcers or in ulcers in general? And it's staph. So we just decided we would continue to work with staph. We're using SB1 from Eliava.
Okay.
So
how did you get that phage? And were you thinking that was going to work? Like, staph will be the thing to target, or was this just available, or how did you come to that decision?
Well, we are getting it. Betty Cutter would get it for research, her research program. So I was able to get some from her. And this, what we're using is the phage that you would buy in a pharmacy in Tbilisi. You walk into a pharmacy, you just purchase a box of 5 vials. And so we were using a commercial grade phage, and it's staph only. And I knew staph has been an enemy for many years. So if something is infected with staph, then let's see how it will work. And so I started putting it on patients who had little choice. It was an amputation or get rid of the infection. And the problem with these patients is that if you amputate the toe, it's not really that they can lose a toe. It's not that big a deal. But the toe amputation may not heal. And that will lead to further amputation up to a below the knee or an above the knee. They have that little blood flow. So it actually becomes a limb salvage, saving the entire limb if you can cure that little ulcer on the toe. So staph was our enemy. So that's what we decided to work on.
Got it. And do you think, like, because a lot of people are saying, and there's research into the polymicrobial nature of any wound, especially these ones too, like, do you think there will be a need for a diverse panel of phages to actually cover the pathogens that end up being here, or is treating staph the only thing you really need to do in your experience?
I would actually, if I had a personal lab and infinite amount of money and work, I would create some cocktails, and yeah, we definitely have to address other phage, or excuse me, other bacterium with phage, but we don't know enough about what we're doing now. So I thought maybe if we added to the body of knowledge about one, maybe we could transfer it to others as well. We're definitely going to need phage banks. We're going to need some customization. We're going to need, like I just pull a bottle of phage off the wall and out of the refrigerator actually, and use it. So
do your other colleagues, other podiatrists that like, how have they felt about you using phage, or people saying, hey, like, I'm curious about that, or people think you're crazy in the beginning, or how has that been received?
well, they probably all think I'm crazy. I don't worry about that. Um, there's been some with interest, and then others are too busy doing what they're doing, and a lot don't want to work with wounds. They are very difficult to work with. They're frustrating. People don't heal well, so they don't want to mess with them, and that's fine. I would rather they didn't. So, but there's been some interest, and I've got a couple other podiatrists, one locally, one one in another state that we can tap on, and for holding larger trials, which is where we're going.
Awesome. Yeah, I want to talk more about that in a little bit. I'm watching the chat come in, so I'm seeing some questions about, we were talking about flora, but also the frequency and dosing and duration. Let's talk about that. So first, how did you even decide that in the beginning, and what have you landed on as something that works there?
Well, it was, I see patients once a week. This is a formal clinic, and we see patients once a week. So I used it once a week. And these are small, very small ulcers. These are not large ulcers. So how would I use it? I had to get it out of the vial somewhere. So I used tuberculin syringes and drew it out of the vial. And then I would, if the ulcer was fairly macular or flat, then I would just apply it to the surface. The first time I put on some phage onto a flat ulcer, I had a little extra in my syringe, and I didn't want to waste it. So I cut a piece of gauze to match the ulcer, squirted it on the gauze. I figured piece of gauze next to the skin, that'll keep some phage next to it, and then covered it with some other material so that it wouldn't get soaked up with anything. And it seemed to work beautifully. So if I have open joints, for example, then I will actually dribble it inside the joint. That seems to work extremely well using tiny bits of phage, 1/2 of a tenth of a cc, for example, inside of a joint. But it really cleans them up. It's tiny. And so dosing is really based on the size of the ulcer. And that's something that we want to look at down the road. We need to formalize that. So dosing and intervals, maybe twice a week is better. We don't know. I've only ever done it once a week. So in our new clinic, we're going to have the ability to do that.
Yeah, new clinic. So exciting, because you are looking to scale this up a little bit more, get it back going again. Is that correct?
Yes. Yeah. We're in the process now of putting a clinic together. I'm kind of joining with a plastic surgeon, and we'll have a surgery center right next door that we can use, and we can use phage however we want inside there. We aren't kind of roped into once a week or something. So that's going to be better. And we have some orthopedic surgeons who are very interested in the use of phage for implant infections. So,
right.
So we can work with them too.
Yeah, no, that's really exciting. Oh, I see another couple questions coming in. Yeah. Okay, so first of all, let's talk regulatory hurdles from Tom Ireland. So what were the regulatory hurdles you faced as you were trying these treatments?
Well, we just kind of ignored them. God love the FDA, but um, we just kind of did it. We used, first of all, it sounds like I had this massive amount of patients. You know, I suppose over the course of 3 or 4 years, we did maybe 12 people.
Okay.
It's just there wasn't a lot of, and we used very tiny amounts, very localized areas, and we presented our first. So it wasn't a case series; it was a series of cases. Sometimes it would be 2 or 3 months between somebody, and we presented at the Evergreen conference. I forget when. Must have been like 2015. And the FDA was right there, and they didn't seem to have any problem with us doing what we were doing. And I think it's because it's so localized, and there was so little amount and so few people that it was interesting for them, and no one ever done it before. So we're going to move away from that and get into some formal FDA trials now. So we're not going to do that anymore.
Oh, go ahead if you're sorry. Do you ever see any non-responders? This is from Gina. So non-responders to the phages that you've tried, and are any risk factors that you've seen that predispose patients to a poor response to the phage?
Well, I think if I'm putting a staph phage on and there really isn't staph there, we're not going to see any response at all. I've always seen some sort of a response. I've never had a patient that didn't respond. Safety-wise, we've seen absolutely no safety issues whatsoever. There's just been nothing. Everything has worked just the way we wanted it to. But the only thing I would think it wouldn't work, if you didn't have a lot of staph on it, then you probably would get a reduced response, because you have to have a certain concentration of bacteria to get it to work really well. And if we don't have that, we can culture out staph, but how much is really there? Because I have to depend on hospital labs to do things, and they're notoriously cheap in their approach to cultures.
Got it.
So that's how.
Okay. So how do you choose patients? What was your process for patients?
We chose patients on the basis of their circulation. We chose patients on really what was wrong. If they had an ulcer with open bone, for example, and I know that these people have circulation such that if we try to just amp that toe, that's not going to heal. Now, these people, this actually becomes a life-threatening scenario too. And the reason is because a diabetic who loses a limb, their 5-year mortality rate can go as high as 80%. It's not something that you want to have. So it becomes a life and limb threatening problem. So if we can save the toe, great. And if we put it in and it doesn't work, we can always go back to try an amputation and see and work along that method. So we really didn't have a lot to lose in that particular case. But we always chose patients where they were up against the wall. We didn't apply it on everyone, believe me. It's just a select few that were really in bad shape. So we had some street people come in that they were in a group of interesting people.
I see. Yeah. Okay. Talking about antibiotics. So do you use phages in conjunction with antibiotics? This is a question from Jan. Have you tried with and without seen any difference? What do you think about that?
No, we had a patient come in with a toe tip osteo. The toe was beet red, and it kind of frightened me. So I knew she was sensitive to a particular antibiotic. I put her on the antibiotic. 7 days later, there was absolutely no response. And it was very sensitive. So what's this all about? So I stopped the antibiotic, and that's when I started Phage. And what I did, I actually used the Phage and I injected. Luckily, it was in a second toe, so it was a smaller toe, and I injected it into the toe and into the toe tip. And within a couple of weeks, the ulcer had healed. We started seeing the erythema decrease, the edema were reduced. And so at that point in time, she was not on antibiotics. So in conjunction, I've never used a Phage with an antibiotic in conjunction. And I have used Phage to avoid infections. I did one of the pictures I sent. Then we did use Phage on a non-infected, wide open wound on a street person that I knew was going to become infected. And we had very good luck with that. So.
Wow. I think because we have a pretty tight-knit group today, I'm going to open the floor if you would like to unmute and ask your question. And just raise your hand and I'll call on you as we're going. We don't have too much risk of trolls coming in, so go ahead and raise your hand if you do have a question as we go. Oh, someone says, how do I raise hand? Great question. There should be a button for you. Am I crazy? I thought there was. Zoom, you never know. Oh, so you click on reactions at the bottom and there should be a raise hand right there. There we go. So Hedy, I'm gonna call on you, go ahead. You should be able to unmute yourself.
Hi guys. This is Sam Penzner. Actually, it's not Hedy yet, but we work together in the iPath lab here at UCSD. I'm infectious disease, and so really interesting stuff. Randolph, I guess I have two questions. Which is, the first one is, do you test the Staph aureus isolate in the lab to see that it's sensitive to the phages before you apply the phages, or do you just give phages if you saw it from the laboratory cultures that they grew Staph aureus? And then my second question is, certainly you've seen more diabetic foot infections than me, but my question is, if you have you seen someone with osteomyelitis where the wound probes to bone and you give phages and it essentially cures them? In other words, and have you been able to see them for a prolonged period of time off of antibiotics? Because in my experience, if the wound is grossly infected and it probes to bone, and it's a chronic infection, which these almost always are, you're going to 90% of the time this person's going to require an amputation if you take them off of antibiotics.
Interesting question. So to answer the first one is we do not test. Now, we obviously we culture the wound, and if it comes back staph, then we have a candidate. I don't test the bacteria against the phage or the phage against the bacteria simply because I have no way to do that. At that time, I didn't. I do now, but I didn't know how to do that. So I figured, this is anti-staph, let's just try it. And it seemed to work beautifully every time. And I know SB1 has a very wide spectrum. So we just lucked out on that. The answer to the second question, I actually have some images that we can show you of a patient, osteomyelitis, what looks like a fragmented metatarsal head, cured. We're 3 years down road now. No recurrence, no antibiotics.
How often have you seen that identical situation with antibiotics, given that it was a chronic infection? I'm just curious in your experience. So you weren't using phages.
When I wasn't using Phage?
Yeah, so if you saw that same, how often would you see a case like that in which you did not use phages, and you were able to cure?
That's a kind of a routine thing that with an osteo that we use antibiotics. The patients that I decided then to try this on had been through an antibiotic phase, and it didn't work. So I tried the phage, cleaned it right up. So, and we have some pictures of that.
I can, do you want me to show the picture I have lined up?
Let's show the pictures, and I can talk about them a little bit, because one of them is going to refer directly to his question.
Okay, so we'll start with the bone one. And just a quick reminder to everyone that we are recording this, just so you know, if you are going to raise your hand. There's always a possibility to edit it before we post anything online, but just letting everybody know. And also the other warning is that some of these pictures are kind of graphic. So just warning you, because these are some crazy wounds, but you're probably all used to that. So first, the bone one I'm going to show. So do you see my screen, my picture? Perfect.
Yeah, you can see here the metatarsal head and the base of the phalanx. This is a 48-year-old gentleman, right third. The base of the phalanx, and he was walking on it, and it kind of fragmented everything. And so I did go take actually I injected first, but there was a piece of the base of the proximal phalanx that had rotated plantarly. So now it created a pressure point. So I had to go in and take that out. But the head of the metatarsal was never touched surgically. And this is not quite a year later, but you can see how much of that has come back. And I haven't seen the guy lately. But if we see him, we can grab him and take a quick X-ray and get a much more long-term image. So, but there was no antibiotics outside of his failed antibiotic trial. It just didn't work. And the problem with this is that radiology missed it, and I wasn't treating him at that time. That he came into my clinic afterwards. He came in like with the left-handed picture. So, and I felt sorry for him, and I knew he'd been through it already, and this is getting worse. And I thought, let's try this. We can always go back and take a chunk of bone out. Didn't have to. So, and I used 12 mils total. I used 2 mils per injection, tried to get it into the bone tissue as much as possible, but certainly surrounding the tissue. And then you could see the reossification, which tells me that the infection was gone. So that's how I did that. And that's how I would approach it from now on as well.
Did you want me to move on to the other pictures, or should we take another question?
You can. And this is stuff that we're going to do down the road. This is where we're going to go. If anybody has any idea, what are we going to do? Because I'm a podiatrist, I can't get too involved with systemic infections. But if they're localized on the legs and feet, I can. So we're going to look at formally infections in toes. We're going to look at osteomyelitis. We're going to look at soft tissue infections. We're going to look at dosing. We're going to look at intervals. We're just going to kind of look and see what's the best way. We don't know really the best way to give them. And I know that's been done in Europe for years. But they're dosing like every day in those specialty clinics. And I don't know, I suppose we could do it here, but let's see, maybe 3 times a week is better than once, or twice is better than once, but maybe 3 times isn't as good as twice. So, or it doesn't affect it. So we just don't know. So we're going to try some of those.
Got it. I'm going to go on to another question about phage and their manufacturing.
Did I answer his question? I mean, are we okay with that?
I think we're okay because oh, there we go. We're back. Hey, Sam. He's happy.
Okay, we're good. Okay. Were you with iPath? Is that what you said?
Yeah.
Because I want to come down and talk to you guys if I can.
come on down.
John, okay. Yeah, I want to make kind of a very miniature eye path, but I want to use, it's going to be more topical and localized infections. If they go
Okay.
systemic, then other things, that's a different scenario. Then we may need IVs. So
I guess I just actually,
anyway,
I did want to clarify one thing. So my question was, so typically from an infectious disease standpoint, we would consider in someone who's got a chronic osteomyelitis, which DFIs are almost always, you would say that they are infected, they're basically permanently infected. So you can only get rid of it with amputation, which is why I was asking, how often do you see, like you mentioned, the ability of that patient who you treated with phages to stop phage therapy and that they're cured? My question is, just so I can get a sense of what you see in your experience, how often have you given someone with chronic osteomyelitis of the foot antibiotics, stopped it, and then permanently not be able to not have to go back on antibiotics? That was my question, the second part.
Oh, that's a good question. There's been a number, because generally by the time we see the osteo, it's chronic, but it's very localized, and we can, if we can't clear it up with antibiotics and leave it and be done with it, then we're going to have to do something surgically. But it's been a great number of times that I've done that, where you go through your period of time. I got people now on oral antibiotics that you can see the osteo. It's in a very localized spot. You give them antibiotics. Within a few days, you start to see the erythema reduced, and you've got it. So you play out the time, and it takes care of it. So it is the kinds that last forever. I know there's one recorded of 81 years later, a recurrent osteo. I don't know how they treated that. So, but that's how, that's my experience anyway. So, and that's my goal, is to treat it so that it's completely resolved. So.
Thank you for that.
Cool. Awesome.
Yeah,
no, good question. Thank you for asking it. Okay, so Edward Bird's question in the chat is, can you talk about, and then after this question, sorry, Joseph, I'll get to you right after this one. So your hand is raised. So can you talk about the source of the phages and their manufacturer? So you said that you could get them from a pharmacy in Tbilisi. Is that not possible anymore, or are you moving to new sources, and how do you expect to get them?
The phages that we used came from the Eliava Institute on a research agreement with Betty and Evergreen. The phages that we're using are commercially available right today. If you walked into a pharmacy in Tbilisi, you could purchase them. And we have some of that now. One of the problems with using that particular phage, and it's a very good phage, is that it's not GMP. It's not good manufacturing. And so we need to find, so FDA wants GMP phage, and this is not. So I'm going to hold some chats with other companies to get a hold of some GMP phage, staff only. We can concentrate on that. And so, and there's some manufactured here in the country that we can get a hold of.
So you're finding things are changing when it comes to phage availability nowadays versus when you started?
When we started a few years ago, we would send messages to the Eliava, and they would kind of ship them right over, and there was no problem. Now it's much more difficult. I think that needs to be tied to, especially into our institution, it needs to be tied to a research protocol that's registered with the FDA. Patients purchase them. They can buy them and have them sent in to them through the mail. If a private person were to do that, but if an institution like ours, then that's a much different scenario. So a little harder. So.
I'm going to ask Joseph. You can ask your question. I'll ask you to unmute. And then Gina, you're up next. So Joseph, go ahead.
Hi, Randy.
Hello.
Nice to hear you. I just have a few questions for you. Just also this one question. Basically, I myself am a virologist, but
Okay.
I chose to dwell on work with phages only after hearing stories from you through Betty. And so here's my question. Apart from SP1, which other kind of stuff do you often use in your work?
I've only used SB1. I've never used any other kind of phage.
Okay. Fine,
Great.
thank you.
Thank you, Joseph.
You're welcome.
Awesome.
Thank you for the
Okay.
question.
My
Thank you
pleasure.
for being with us.
Yeah, thank you for coming. Okay, Gina, you're up next. Go ahead.
Thank you so much. This is really fascinating and really extraordinary, I think. I've treated many, many, many wounds, infected wounds, osteomyelitis, prosthetic joint infections. And this is the topical application that you're describing is really cool. My question is, I have two questions. One is, have you treated hindfoot and or midfoot infections? Calcaneal osteo is a big problem when the metatarsals become infected, or has it been mostly the distal phalanx?
It's been mostly distal. I haven't done a rear foot. I wouldn't be afraid of a rear foot if I had one like that. I would,
Yeah,
I'd use the same technique.
Okay. I think that would be really interesting because, as you know, calcaneal infections, once the calcaneus becomes infected, it's impossible to, remove part of it. The patient can't walk and they end up with a much more proximal amputation. So I'm just curious, that might be really interesting to see. And then
if I saw one, I would attack it.
Okay.
But I haven't seen it. So the ones I've seen were all hospitalized at the time, and hospital isn't going to allow me to do that. So I had to I haven't had a chance to treat a calcaneal osteo yet.
Mm. And my second question is, if patients are being treated topically with non-GMP phages by you, and as they have been in other parts of the world, including Tbilisi, you can make an argument that GMP manufacturing is not necessary for all preparations of phage from a regulatory standpoint. And I wonder if anyone has any insight on the call from the regulatory standpoint as to whether GMP manufacturing is a necessity. Is that a standard because that's really the bottleneck in a lot of, for phage manufacturing. It's astronomically expensive and makes it unreachable or not feasible. So I wonder if anyone has any insight as to whether or not we are expecting to have to go through the GMP route if we are to treat phages in this country moving forward.
Boy, I haven't seen one iota of literature addressing that. And the FDA, if you can change them, bless you. I will join your army.
Yeah, but I think we can learn from non-FDA entities, the European societies and other regulatory bodies in different parts of the world. So, yeah.
Yeah, and I think that, I think I think they were after the purity is really, they want to make sure that every phage coming out is exactly like the other. There's no impurities, no endotoxins, no other products inside there. And while Eliava has been making these for a long time, well known, I don't know about other companies. So
I think so I'm going to get to you, Natalie, but I'm wondering if Edward, you raised your hand in response to Gina's question. If you did, you can go ahead.
Yes, I wanted to talk a little bit about the question of GMP, because I think we're mixing up what GMP means versus some of the requirements of manufacturing. FDA has a sliding scale of GMP compliance for drugs that are being developed as a way to help foster development of new therapeutics. And Dr. Fish talked a little bit about what some of the requirements are. And those are ones that aren't necessarily all what we would call full GMPs. So there's a sliding scale of compliance, and you should be aware of that. It's full GMPs if you want to license or conduct a phase 3 trial, because you need to have the material that you would commercialize, because that's what you're testing in your phase 3 trial. But for these kind of phase 1 type studies, there should be a lot more flexibility, especially if they are single patient type of treatments. But again, the issue may very well be that FDA is using enforcement discretion, which is why Dr. Fish hasn't been shut down. And enforcement discretion is where they choose not to enforce the IND requirements. So it's a bit nuanced, but full GMP for these early activities are not required, typically.
So that, just to follow up, so that sliding scale would take into account route of administration. I would imagine that topical preparation wouldn't be held to the same requirements as an intravenous preparation.
Correct. You could have higher levels of endotoxin, maybe host cell protein, contaminants, and those sorts of things. It can very much be on a case-by-case basis as to what the requirements for testing would be. But again, the testing doesn't necessarily have to be fully GMP compliant testing as you would use for commercialization. These can be qualified assays, but not fully validated, and so on.
Yeah, no, I mean, I understand that the compassionate use cases would have different kind of standards, but my question is really, looking ahead toward commercialization, whether or not the regulatory standards would be, more than what's necessary for a certain, so topical preparations, et cetera. But anyway, I'll stop there.
Thank you so much, Gina and Edward. That was really good to have your 2 cents coming in here. And yeah, and I see some people in the chat mentioning, like Adriana, talking about how for emergency interventions, just endotoxin is what's required, and some others mentioning in there. So that's awesome. Did anyone else want to follow up on this topic before we shift topics again? We'll get to Natalie's question, and then I want to do a breakout room so everybody can have a chance to meet in small groups at least once. So Edward, if you had anything else to say, Gina or Randy, on this topic.
No, I'm done.
I could jump in here really quickly also because this dovetails really well into my question here. I could start the video. Hi everyone, I'm Felix's head of BD, and I also act as our interim head of clinical dev, working with the DL team on the SIFI study. To this point, Ed is right. They're Ed and Gina are both spot on. There's like a bunch of different gradations of what the FDA considers GMP, and that's not only within pharmaceuticals, but there's a food grade GMP as well. And so, you know, it's going to vary, but I think one thing to keep in mind, and I think the reason the FDA has, you know, been, I think, generous to the phage community in terms of how we use as an emergency INDs, but is pushing us all toward more formalized GMP is because they are an agency primarily concerned with safety and quality, right? Like they were born out of the sulfonilamide elixir disaster in like 1930s, and they recognize that like one like bad case could shut most of us down, right? It could, one bad story can really destroy an entire industry. Like look at gene therapy. So like, I do see why they're doing it. I think to Gina's point, there is a chance for us to maybe work with them to define what that GMP means in the context of phage though, right? Like they set endotoxin levels that differ for systemic versus topical versus inhaled, and figuring out with them what's the appropriate safety, you know, as Randy mentioned, like publishing on that, the cases, what we have used and where we have not seen adverse events is going to be incredibly valuable in making sure these things get to patients quickly, but also again, safely. So if we can shift topics now really quickly, and this again ties back into Gina's question about sort of how we get these things to the commercial dev. Randy, I know we chatted earlier, but really thinking about like an ideal world, what would this look like? How do we make this a generalizable therapy accessible to everyone, and sort of thinking about sort of the clinics that are spinning up now, commercial product dev pathways, like how do we get you reimbursed for doing this kind of work, basically, right?
You know, getting a product reimbursed through insurance companies is incredibly hard. They're going to have to do many phase 3 trials, and you know they're going to have to go jump through the hoops. And then once the key there, I think, is Medicare. If you can get Medicare to pay for it, everyone else kind of goes down the line with what Medicare wants. So I think that's the kind of the key block there. And beyond that, I don't know. I'm willing to help. I'm just kind of a country doc, but I'm right in there.
Thank you.
Thanks for your question, Nat. That's awesome. Glad it connected so well. So if there's no other questions right now, although I did want to mention Amina's point about bone, I think this is really interesting to point out, like that the issue is that if you're injecting products into the bone, you could get systemic absorption, and then regulation might end up needing to apply as it would systemically, even if it's applied somewhat topically. Is that something that you worry about, Randy, or think about on that
Well,
side
you
of
think
things?
about it, generally with what I've done, there's been so little injected, there can't be much that's getting into the systemic system. And you got to remember too that you have a bone infection, you really don't have a lot of circulation in that area anyway. It's not a highly vascular area. It's not a highly vascular patient. So they're definitely absorbing, and it's getting into the system systemically, but I don't know that we're getting in that much. But it's a valid point. Do we have to worry about that? And the topic brought up earlier on a calcaneal osteomyelitis, you can use a lot bigger quantities. Especially, what about a joint implant infection? Because now you're going to take larger quantities and get it in and around the joint. So that's going to be interesting to look at and work with the FDA. You call them up first and see what their opinion is on it, and then you can move forward with that. So that's what I would do.
Awesome. Okay, so I'm going to take us into our breakout room. So just this is informal. I'm going to stop the recording. And so, yeah, this is just to bring you together, meet somebody new. If you're not into this, feel free to go on with your day. Thank you so much for coming. This has been a really cool chat, and cool to do this new format with kind of a smaller group, just more interactive. let me know what you like and dislike, and we can make things happen kind of that way in the